Good afternoon. This is Julie Willems Van Dijk, Deputy Director of the County Health Roadmaps Program, coming to you from Madison, Wisconsin. Today we're here to explore the hospital community benefit requirement and how it can enhance your community health improvement efforts in your community. I'm very pleased that we have Jessica Curtis with us, who's the Director of the Hospital Accountability Project at Community Catalyst, and in just a minute I'll introduce you formally to Jessica. Well, there's her picture. So you have a visual connection to Jessica and myself. We're both very excited to be with you this afternoon. So some of you may be new to GoToWebinar, and so I just wanted to spend a moment explaining how you can interact with us. In GoToWebinar, you have two different items on your screen. The first is your viewer window, and you should be seeing slides that are being projected from my computer right now. And then in the upper right-hand corner, you see a control panel. And if you click the little orange arrow at the top of that control panel, you'll see what is on the slide here in front of you. You can listen to us through your computer, and if you're hearing my voice clearly through your computer, there is no need for you to dial in. If you're having problems hearing through the computer, you could click the Use Telephone and dial the number and access code that you see on your screen and listen to the broadcast through the telephone. We have several hundred people registered for today's webinar. We're really pleased with the turnout today. Therefore, however, it would be very difficult to handle questions via the phone or verbally. So we will reserve a good 15 to 20 minutes at the end of the webinar for your questions, and we encourage you to type your questions into the question box that you see on that control panel and send them forward to us. Feel free to send a question forward at any time during the presentation. However, we won't be answering them until towards the end of the presentation. I'd like to begin by acknowledging our many partners in the County Health Rankings and Roadmaps project that bring this webinar to you today. Most notably our colleagues at the Robert Wood Johnson Foundation and our colleagues here on the Wisconsin County Health Rankings and Roadmaps team. And many partners throughout the nation, most notably today, Community Catalyst, who is our partner in the Roadmaps to Health project. Our colleagues at Community Catalyst lead our Roadmaps to Health Community Grants program, and we're thrilled that one of their colleagues, Jessica Curtis, is with us today. So here's what we'll be doing during the next hour. Jessica will be discussing community benefits and key legal requirements and working on how to connect community benefits to other health policy goals and strategies for improving health. And then when she completes her presentation, I will explore a few examples of how hospitals, public health, and other community partners can work together. And then, as I mentioned, we'll have plenty of time for questions at the conclusion of our prepared remarks. So I suspect many of the members of our audience are familiar with the County Health Rankings. The County Health Rankings is a project that provides an annual checkup of the health of your community. We're not going to be exploring the rankings themselves today, but just wanted to highlight for you that you can find your County Health Rankings at our website at countyhealthrankings.org. The whole point of the County Health Rankings, however, is to use data, to use the way we present that data with a focus on the many factors that influence health to drive action in your community. And we know that if we are going to focus on those many factors, such as health behaviors and clinical care and social and economic factors in the physical environment, we need everyone working together that you see in the middle of our Take Action cycle. So today's webinar is really focused on how we can partner with our healthcare colleagues throughout the nation to meet the requirements of community benefits that our not-for-profit hospitals are required to attend to, and how we can do this in a way that helps advance health for all in our community. So To help us understand the hospital community benefit, I'd like to introduce you to Jessica Curtis. And as I mentioned, Jessica directs Community Catalyst's Hospital Accountability Project. In this role, she provides a broad range of policy-based, legal, and strategic assistance to community organizers, advocates, and policymakers, spanning a range of issues related to hospital community benefit programs. Key areas of focus include strengthening collaborations between hospitals and communities, building community capacity and engagement in hospital community benefit programs, and addressing hospital billing and collection issues that contribute to medical debt. Jessica served previously as policy analyst and staff attorney for Community Catalyst's Integrated Care Advocacy Project and Special Needs Plan Consumer Education Project, where she focused on structuring payment and delivery system reforms to benefit vulnerable populations. Prior to joining Community Catalyst, she provided legal advice and services to low-income elders at Boston College's Legal Assistance Bureau. She holds degrees from St. Joseph College and Boston College Law School. So, Jessica, take it away.
Well, thank you, Julie, and I'm really pleased to be on this call with all of you. Looking forward to the discussion at the end in particular and the ability to answer some of your questions and hear more about the work happening in the field. So I'd like to just start by talking really briefly about the evolution that we've seen in community benefit. And as Julie walked through, I'm going to talk a little bit about what community benefit is and some of the key legal requirements before we talk about how community benefit might connect to some of the goals that you have for your communities. I also wanted to just flag that I know that there's a wide range of knowledge and experience related to community benefit on the call, so I apologize in advance for those of you for whom my presentation is really a significant review of things you already know, but hopefully what I'm discussing will be helpful to those of you who might be newer to community benefit or have struggled to understand why it's so complicated to get hospitals and public health departments and community groups working together. So although my remarks are going to focus on the legal requirements surrounding community benefit, I think it's really important to recognize that community benefit is a planning tool. It's really not just a legal imperative. We see it here as more of a practical way to organize hospital, community, and public health resources and interventions. And traditionally, the focus for community benefit has been focused on creating access to care through making it affordable primarily through charity care and financial assistance programs. So that's represented here by the ambulance. And most people think of community benefit, and when they think of it, they think of patients who don't have insurance or don't have adequate coverage going through the emergency room. That's still, to some extent, the broader component of community benefit, and we'll talk a little bit about that later on. But if you can advance the slide, Julie, one of the things that we know is that community benefit is being thought of much more broadly as an opportunity to really promote health, reduce illness and injury, and address the social determinants of health. And that is a shift, at least among thought leaders, maybe not so much in practice, in how community benefit can really be used in the field. So going to the next slide, we're going to look at a couple of really important ways that community benefit obligations arise. And I think that this is one of the areas where we policymakers have unintentionally created some confusion. Community benefit obligations can arise from a variety of sources, but the most widely applicable is the federal standard that applies to tax-exempt hospitals. So I want to just really quickly review 3 key sources of information about community benefit that apply to tax-exempt hospitals, which make up about 60% of the hospitals in the nation. So tax exemption is the source of the federal legal standard, and this means that an agency that we don't typically think of as a public health or health-related agency has oversight of community benefit. The IRS and the Treasury Department develop the guidance and handle all of the oversight related to community benefit. And they have defined community benefit through their guidance for tax-exempt hospitals in a 1969 revenue ruling that says the key question is really, does the hospital promote the health of a class of persons broad enough to benefit the community? So as you can see, this is a very broad and very vague definition of community benefit. It's still a good definition of community benefit, but it doesn't answer that many questions about what community benefit is and what it isn't. Two other things that I think get closer to that include the public reporting form that tax-exempt hospitals have to file every year with their tax returns. This is Form 990, Schedule H, and we'll walk through that briefly in a moment. And that really outlines all of the categories of things that are automatically reportable as community benefit. It's something hospitals have to file, and it's something that public health and community partners can really look to understand in retrospect what were hospitals thinking about and doing with their community benefit programs. And those forms are also a fairly new development. They were introduced in 2008 to increase transparency with hospital community benefits. The last development that's important to know at the federal level is that the 2010 Affordable Care Act added new requirements for tax-exempt hospitals. A number of these just relate to additional consumer protections for patients related to hospital bills. So you see financial assistance policies, billing and collections practices. And one of those, which is really the topic that we're going to talk about today, is that hospitals now must conduct regular community health needs assessments and develop implementation strategies on a 3-year cycle. So before we talk about what some of the ACA requirements are, on the next slide we'll talk a little bit about some of those categories for community benefit that you can find on the Form 990 Schedule H. And here on the left you see the list of things that are automatically reportable. If you look down past the first bullet, you see financial assistance, subsidized health services, Medicaid shortfall. This is in instances when there are government programs that are means tested and intended to provide access to care, health research, training and education, cash and in-kind contributions to community groups, and the ubiquitous other that covers many categories. If we advance the slide, though, I want to pull out this top bullet, community health improvement services. This is something that I think is a really exciting area of community benefit that probably isn't being invested in as much by hospitals, but it's still important to know about. Community health improvement services can include a wide variety of things, including what we talk about as community building. And this can include physical improvements to housing, removing building materials that harm the health of residents, developing or maintaining parks and playgrounds to promote physical activity. It can include economic development, community support, including disaster readiness, public health emergency activities, environmental improvements, such as addressing environmental hazards, alleviating water or air pollution. But it can also focus on leadership development, coalition building, and advocacy around community health improvement services. And the way that hospitals can claim these activities as community benefit is by demonstrating that there is a community need for that activity or service that comes from either a request from a public agency, a community group, or the community health needs assessment, or partnering with a government agency or another nonprofit. In addition to showing that there's a demonstrated community need, they have to show that the program in question meets one of the objectives for community benefit, which are listed here, reducing barriers to care and leveraging public health efforts, among others. So moving to the next slide, we see some examples of community benefit programs, which you may or may not be familiar with. Some of the ones, again, this is in addition to things like financial assistance or charity care, as it's commonly called, can include providing funding and staff to community health clinics, providing access to specialty care services or diagnostics. It can include obesity prevention measures. A common one currently is sponsoring food banks and working to bring farmers markets and other kinds of healthy foods to food deserts. It can include supporting community coalitions on issues that are really wide-ranging. Some of the ones that I've heard about include reducing coalitions that reduce youth violence, address substance use, increase youth jobs, for example. And again, it can include linking low-income patients to other kinds of health services that aren't typically really available to them in the community, such as dental, vision, or mental health services. So that is really what you will find on Schedule H, and the reason that it's important to know these categories and to understand Schedule H's role in this whole equation is that it can really drive how hospitals are thinking about community benefit, especially if you're working with a hospital or are in a hospital where the focus on community benefit is really oriented around compliance. This is a really important document for you to become familiar with. So the next piece of the federal equation that is important to know about are the requirements that came out in the Affordable Care Act. And I think that this is an area that's a little bit hairy, and lots of people have questions because of where we are in terms of the rulemaking around this requirement. So the ACA did require hospitals to set up these 3-year cycles of conducting community health needs assessments and developing implementation strategies. And that's something that I think most people at this point are familiar with. But as we know, the statute really just put out a skeletal requirement. The details behind that have been coming out in dribs and drabs from IRS and Treasury, and we still do not yet have final rules for hospitals. The requirement went into effect for hospitals, this particular requirement anyway, for tax year 2012. And part of what makes this so confusing is that there's not a date certain by which a hospital in your community will have to have complied with the law. Because it's tied to their tax years, the deadlines that a hospital will have are going to vary. And the most important way that you can find out what their deadlines are simply to ask. That's one area of complication. The other area of complication, as I mentioned, is that there are different ways and different sets of guidance that a particular hospital might be using to comply with the statute. So the IRS issued some initial guidance in 2011. And that laid out the terms that hospitals had to abide by or could abide by to conduct their community health needs assessment. But it also issued proposed rules on the community health needs assessment and implementation strategies, and those just came out in April. We have not yet seen final rules on this, and when people ask, well, when will those final rules come out, I have to consult my magic 8-ball here, which says, as you can see, cannot predict now. We know that the IRS and Treasury Department are working on other aspects of the requirements for tax-exempt hospitals, and they've indicated that they intend to put all of that out together, whether it's dealing with financial assistance or community health needs assessments and implementation strategies, but we don't have a good timeline from that at this moment. So what this means practically for hospitals, however, is that they can rely on the initial guidance that came out for hospitals. And we think that most hospitals have actually completed the first round of their community health needs assessments or are coming very close to that. And they should be morphing now into that implementation strategy phase. Again, there's guidance now on the implementation strategy in the proposed rules, and there was guidance in the notice from the IRS that came out in 2011. Hospitals have the option of following either one of those sets of guidances and still being in compliance with the law, and the deadlines are going to fluctuate to some extent based on their individual tax years. So the best piece of advice that I can give to you if you are trying to work with a hospital and understand these deadlines is to really ask them what their tax year is, what deadlines they are observing internally, and then from there back up and try to identify ways to partner together. So it is still possible, despite this lack of clarity around the rules, to really understand what it is that hospitals are being asked to do in the federal guidance. If we look at the ACA together with what the IRS has put out in initial guidance and what they've put out in the final rules, there are a few things that they must do. And again, these are nonprofit tax-exempt hospitals. They must conduct a community health needs assessment at least every 3 years, and they must adopt an implementation strategy. You can go back to the slide before this, Julie. Actually, there you go. In the process of conducting that community health needs assessment, hospitals have to define the community that they are serving for purposes of the assessment. That can be a smaller subset of the populations they normally see, can be a larger subset if they've decided to focus on a vulnerable population that doesn't normally use the hospital for services. But what they cannot do is exclude patients that are vulnerable for a number of reasons, whether it is income or race, ethnicity, or lack of insurance status. So they must define the community served, and they must get community and government governmental health department's input into that process. They've got to assess and prioritize community needs. And then they need to document and widely publicize the community health needs assessment. And that is a document that will ultimately be available to the community to input and provide feedback on. The second thing that hospitals must do is adopt an implementation strategy that either describes their plans to meet the needs that they uncovered in the assessment or describes why they will not be meeting a significant health need and gives the rationale. In addition to this, they must have the hospital board adopt the implementation strategy, and this document, at least under current iterations of IRS rules, will be made public, but not as immediately as the assessment. It's something that hospitals will file with their Schedule H tax return. So from a community and a public health perspective, there are some ways to provide feedback. One is to provide feedback during the assessment process. That's something that hospitals are required to seek from community and public health partners. But you can also provide feedback via written comments on the community health needs assessment or the administration strategy. To think about or hard for community and public health work on and understand is that although these process requirements are part of the federal law, a lot of how hospitals actually carry out the requirements are up to them. So the IRS was very clear that hospitals are allowed to collaborate with other partners in conducting the assessment and carrying out implementation strategies. They were very clear that they want some level of community and public health input into that process. They were clear that they want some levels of transparency, and they want hospitals to be thoughtful about how they're looking at community needs. But they left hospitals a lot of discretion in terms of whether and how and to what extent they collaborate with other partners, the depth of the input that they're requiring, what data they're looking at as part of the assessment, and even what is a priority health need. And I think that those are areas of questions that many commenters in the last cycle of comments flagged for the IRS, but we won't know how they're going to handle that until we see final rules. Moving to the next slide, another area that's complicating community benefit for many hospitals is that some states do have their own requirements around community benefit. And for a number of states, these are requirements that have been in place for a long time. What this means is that hospitals will be starting at different places in terms of completing community benefits or familiarity with the concepts. And this is particularly true when you look at issues such as public health and community input that's required, which is on the next slide. So if we look at some of the slides, some of the state requirements, we see that only 14 states have required hospitals previous to this to do any kind of community benefit planning. 10 states require hospitals to do assessments already. 9 states require them to do implementation plans. 10 states require some level of community input, and 6 require some level of public health input. That leaves a lot of states where these requirements are going to be potentially very new, although there certainly are hospitals that have done community benefit planning processes before and have been using guidelines established by groups such as the American Hospital Association or the Catholic Health Association. But it does mean that there will be differences in approaches that are going to need to be navigated by public health and community partners. So one thing that I wanted to flag as a consideration as well is thinking about how hospitals have been investing community benefit dollars historically. So if we look at the next slide, there has been some initial research done on the reporting that hospitals have had to do for the IRS, that Schedule H form that I mentioned earlier. And as you can see here, hospitals across the nation on average spent about 7.5% of their operating expenses on community benefit. More than 85% of those expenditures were still devoted to access programs, charity care, Medicaid shortfall, etc. Only 5% was spent on community health improvement or some of the broader issues that really go to the heart of social determinants of health and upstream factors that impact health. The rest was split between education, research, and community group contributions. So this is interesting because we are in, I think, in flux in terms of our healthcare system and how we're thinking about whether hospitals and healthcare providers as a whole should be focusing on getting us healthy or keeping us healthy and preventing us from becoming sick in the first place. There certainly has been a lot more conversation about using community benefit to address the upstream determinants of health, but at least in 2009 when, and 2008 when this data was recorded, it looks like hospitals are still spending most of their community benefit dollars to address access issues. And if we go to the next slide, you know, some of the questions that raises for us here at Community Catalyst, you can keep going past the slide, Julie. Thinking about how community benefit will play into some of the other factors that are going on around the country. For example, the impact of the Medicaid expansion and whether or not hospitals will be able to shift some of the resources away from charity care and Medicaid shortfall. That really can be impacted by state policy decisions, whether or not states decide to expand Medicaid. One thing we know from Massachusetts experience as well is that although coverage expansion actually did reduce the amount of uncompensated care, which includes charity care here in the state, there still is significant usage of charity care and uncompensated care dollars, and we suspect that that's partially because there is an increase in the number of patients who are underinsured, moving out of that uninsured category, but increasingly they are underinsured as well. So this tension between using community benefit to support access and using community benefit to address upstream determinants of health really is alive and well, and it's going to be something that will need to be negotiated at the local level, taking all of the factors around local and state health policy decisions and community needs into account. So with that, I want to shift gears a little bit and talk about what's been happening in the community benefit field. Some of you, I think, have probably participated in a community health needs assessment process already. Others of you might be wondering if one has been going on around you and you didn't know about it. But I think that there has been a lot of discussion about the assessment component of the new requirements for hospitals, less a discussion of what it means to actually implement a strategy that would address some of those needs. There are some new resources that are out there that are intended to help hospitals, particularly critical access hospitals or rural hospitals that may not have the luxury of having a dedicated community benefit staff person, really understand the assessment process. And some of these tools, such as the one in front of you, which is from CHNA.org, are also intended to help health departments and community organizations that are interested in understanding what's going on in their community. So what we have here is a sample process that is suggested by CHNA.org, which walks through some of the questions you would want to ask doing an assessment. First, you see that under choosing geographic parameters, thinking about who the community served by the assessment will be. What are you thinking about in terms of drawing the outlines of your assessment process? And then moving from that to gathering data, and that includes not just quantitative data that's available from public health departments and other sources from the hospital itself, but also, I think, quantitative data that the community itself can provide and help to flesh out what that other quantitative data is showing you. From that, you can move on to identifying and prioritizing the health needs that you would want to address in the implementation strategy. And I won't go through the details of this process, but somewhere along the line here, once those needs have been identified, once the community has been selected, once you've had an opportunity to talk with other partners, hospitals will come out with this community health needs assessment report. And then the idea is that they will shift gears to really developing an implementation strategy, hopefully that will include other partners. What we are imagining is that the community benefit process will be one way of identifying all of the assets and all of the needs that exist in a community and really building a collective desire and collective will to work on those issues based on the resources that different kinds of organizations, different aspects of the community bring to the table. So one example of this from Children's Hospital Boston is illustrated on the next slide. And Children's Hospital Boston, here in Massachusetts, we have had community benefit guidelines from the Attorney General for years and years. there's a deep history of transparency around community benefit, and this is actually something you can pull down right from the hospital's website, which shows how they think about assessing community health needs. So if you're looking at this slide from left to right, you can see that as part of the assessments that they do, they look at some of the healthcare issues that we typically think about as community benefit, access to health services, different things that would fall into more of a public health bucket. But they also think about some of the non-health related issues, they call it here, social determinants of health, things related to poverty, to income, and educational opportunities that many hospitals might not be thinking really falls within their purview. At Children's, they think that these are things that matter to the community, they impact health, and so they've decided to include those in their assessment. And then as you move further down, you see that they've really divvied this up between things that the hospital can tackle on its own that make sense to handle from inside the hospital, and then things that really need to be addressed outside of the hospital where they can provide support through staffing or data or financial resources. And then that breaks down into the different categories that you see on the right, things you would expect a hospital to deal with, and then other things that are not needs met in the community, such as dental, psychiatry, mental health issues, and then workforce development, education, violence. So that's one example of how one hospital system has looked at both of the healthcare issues and then the broader upstream health issues and worked on divvying up what can be done about that between the hospital and between community and public health partners. So moving on to the next slide, we can also see, I think one thing that's important to really think about and to understand is that this is intended to be a fluid process. The community health needs assessment, the implementation strategy, to some extent there's going to be a really fluid process over the next couple of years. The IRS did not intend hospitals to do this once and be done with it. This is something that hospitals, if they have just completed their first assessment, will be moving into their implementation strategy phase really shortly, and before they know it, it's going to be time to do an assessment again. So if you feel that you've missed the boat, weren't involved in the assessment this last time, or would like to figure out what it was that happened in the assessment and want to evaluate it, there's still plenty of opportunity for you to get involved. You can look at the published report that comes out from the hospitals. Some questions that we like to focus on here really are directed towards understanding how involved the community has been in the process. Were they involved at the beginning? Were they involved in selecting data that should be included? Were they involved in the implementation strategy setting? Were they involved in prioritizing needs? But these questions also apply to public health and other partners. And I think that they give a way forward as well to think about if there are missing pieces that you see, if there are voices that were not part of that process that you think are imperative to be included moving forward, you will have opportunities to do that. And the rules that are coming out from the IRS will further specify that. But in addition to what's laid out in the Affordable Care Act, I think it's important to remember that you can always just approach community benefit staff at the hospital about this process. You do not need to wait for a formal process to start or to stop. One other final thing I should mention as well is we've been talking mostly about the federal requirements for tax-exempt hospitals. And as I mentioned at the beginning, about 60% of the hospitals in this country are tax-exempt. However, the other 40% might still be involved in some sort of community benefit planning process, and if they are not, there are ways that you can approach them as well. So there are states that have community benefit type requirements, municipalities that have those types of requirements. You can also look to certificate of need agreements, mission statements, whether you can appeal to the concept of social and corporate responsibility. There's increasing evidence that having hospitals address population health issues will save the healthcare system and even the hospital money over time. But the last bullet here is really where I'd like to end, which is just to say that what's now part of the requirements for tax-exempt hospitals federally is not really a new idea. It's something that public health has known about for a long time, and these are things that many hospital and public health and community leaders have been pushing hospitals to do. So, there are lots of ways to pull on the strength of the crowd and encourage these other types of hospitals to join the bandwagon around community benefit. And Julie, I will turn it over to you.
Thank you so much, Jessica. That was a great review of community benefits and a lot of really rich information there. Before we move into questions and answers, I thought it would be helpful to think through some of the partners that also have an interest in conducting community health assessments and improvement planning processes. I know our audience includes a wide variety of people from different sectors. So we have people on the call, on the webinar, who come from hospitals. We have many folks from public health departments. We have many folks from other community-based organizations. So wanted to highlight that for many local public health agencies, public health accreditation is an important new concept that's in place. This is the first national accreditation system for local, state, and tribal public health departments. As you see, it was launched in September 2011. There are now 14 accredited health departments and many more in the pipeline throughout our nation. One of the requirements that a public health department must meet if they want to apply for public health accreditation is that they must complete a community health assessment and a community health improvement plan. And similar to the requirements of the Affordable Care Act for hospitals, these standards also require that public health departments do that in multi-sector partnerships with other key leaders in the community. The FAB requirements also focus public health on thinking about those multiple determinants of health, and so it presents a really great opportunity in a community where a public health department is considering public health accreditation, a local hospital has a community health needs assessment and implementation strategy requirement from the Affordable Care Act, for those two entities to work together to do a collaborative process. Now my understanding, and Jessica feel free to correct me if I'm wrong here, but my understanding and listening to many presentations on joint community health assessments is that that is absolutely an acceptable way for communities and for different entities within a community to approach this. However, because of the requirements through the Affordable Care Act, the hospital is still required to produce a document that is their community health needs assessment. Likewise, the FAB board would expect a local public health agency to have a document that's their community health assessment. However, there's no prohibition from those documents looking exactly alike or very, very similar, but each branded through their own organization to demonstrate that they have fulfilled the requirements that are before them. We have a number of other entities within many, many states that are also interested or have skills in conducting community health assessment. One of the entities that we work with through the County Health Rankings and Roadmaps program is United Way, and many of your local United Way organizations also are very interested in assessing the needs of the community and may be excellent partners in doing collaborative needs assessments in a community. Likewise, state university extensions often have skills and data and rich resources to contribute here. I put a logo from the North Carolina Association of County Commissioners. We are also working with the National Association of Counties, and many of your local county commissioners and local county governments or municipal governments are working on planning for the wide range of needs in the community, and either can offer excellent data and resources or be part of a collaborative process to do these kinds of assessments together. The Wisconsin Primary Health Care Association and many, many states have a similar organization. It's the Organization for Federally Qualified Health Centers, or your federally funded community health centers, who also have a mandate to conduct periodic community health assessments. And many states have a formal system of community action programs who also have a formal requirement from the federal government to conduct community health assessments. So this is a sampling of the types of community-based organizations that may also be in this same water about community health assessment and would be excellent partners. Now there's a lot of different ways of approaching that kind of collaborative work. Some of the models we've seen are that organizations may share some kind of resource, like for example, different organizations may help sponsor a survey of the community together, and then each takes that information and does their own independent assessment. Another model is where groups come together and have shared governance and shared resources, but one agency then is contracted to do the primary work. So for example, in one community here in Wisconsin, several hospitals, several health departments, and the United Way all have joined together, shared their resources, and then the United Way has been the entity that led that community health assessment effort. Another option is where you have shared governance and pooled resources, and you actually, as a collaborative, hire staff to do that work. So just examples of a couple of different ways that that work can move forward. And Jessica gave you a great example from Boston about the work that Boston Children's Hospital has done. And here's another example from Milwaukee. And what they have done is come together a number of health systems, a number of local health departments, and they've done a coordinated community needs assessment. And you see the website on the slide here, www.mkehcp.org. That's through the Milwaukee Healthcare Partnership. They have just published that community health needs assessment, and you could go to that website and see the example of this work. And now what each organization is doing is working on, they've identified some shared priorities within the community, and now each organization is working on their specific plans to contribute towards addressing those priorities. And their vision is that they will come back with those individual plans and work on shared community investment for how they will provide the resources to move that forward. So again, the website is there. If anyone's interested in learning more, I'm sure our colleagues in Milwaukee would be happy to share that. So that gives you a few specific ideas of how you might move this work forward, but as promised, we wanted to be sure and have plenty of time for questions here. And so my great colleagues here at the University of Wisconsin have been looking at your questions, and if you give me just a moment, I will start to focus some of those questions that we can focus on. So Jessica, we have a question here about input. So what characterizes input from public health and community members in the community health needs assessment process?
Yeah, that is a great question, because that's one of those areas where the IRS has really left it up to hospitals' discretion. So what they have been a little bit more specific about, and they got more tailored about it in this second set of proposed rules, was who exactly has to contribute that input. They narrowed the public health requirement to really be a governmental public health department, and they said that the community input had to come from members of medically underserved, low-income, and minority populations in the community served. Medically underserved includes those who are at risk of not getting access to care for insurance or financial barriers, or who are suffering or at a disadvantage with relation to health equity issues. So they got more specific about how the input has to, who has to give the input, but they don't really say how that input has to be taken or received. What they do require is that hospitals describe in their community health needs assessment report who they talk to in terms of the organizations, that they consulted and the tactics they used, whether that's a community forum or a survey or something else that's much more intensive, but they don't actually say this is what you've got to do. One of the questions that I think has come up, one of the challenges around that that we commented on, and that I know that a number of public health organizations have also commented on, is that that really means that community engagement and public health engagement in the process can be very, very minimal. And there were concerns that, the hospital could set up an assessment that actually was not going to really take into account what the community or public health priorities were, but that was going to end up looking very much just like the hospital's priorities. So that's one of those areas where I think local engagement is really going to be critical and important, and you're really going to want to talk to your hospital about how they're doing community input, and if you have ideas on ways that they can strengthen that, to suggest those ideas.
Great. Thank you. Here we have a question about interpreter services. Why can't interpreter services provided to patients be counted as a community benefit? There's no reimbursement for interpreting services. It's provided at no cost, and it impacts our most vulnerable populations. According to our CHNA, language is a huge barrier for accessing quality health care. Although our hospital provides interpreter services, yet language continues to be addressed, and it sounds like this questioner understands that interpreter services cannot be considered as part of the community health benefit. Jessica, do you have thoughts on that?
Yeah, and I would say, this is always, there are a lot of gray areas where I think people hesitate sometimes to claim things as community benefit that can count when the IRS has not specifically said or addressed that issue in its guidance. I would say that, again, this is a question for the local lawyers and compliance officers, but when I look at the IRS community benefit guidelines and I look at that area of community health improvement services, if there's a demonstrated community need for interpreter services and it's coming directly from the community health needs assessment or something that's been requested by a public agency or community group, and it meets a program objective, which includes reducing barriers to care, to me that seems like it could fit in under that community building, community health improvement category. But that I think is, again, one of the issues that can be a little bit squishy because of how the IRS has structured its guidance. So I would encourage you to take another look at that guidance on Schedule H and the instructions in particular, how they define some of those terms. It may be that the hospital is just not claiming those because it hasn't thought to include that as community benefit, or they may have just done their own assessment and thought, well, we really don't want to run the risk of putting this on the form if the IRS isn't going to count it in this particular way. But I think there could be a strong case made for it.
Great. Well, this is a question that I alluded to in giving some of the examples I did, but Jessica, I'd love for you to weigh in on it. So the question is, can hospitals work together and do a joint CHNA for a shared region, whether they're part of the same corporation or whether they're distinct or not? But can hospitals work together and do a joint CHNA for a region?
Well, and I thought your answer was great. Yes, there can be collaboration between hospitals, but as you said, the IRS has been pretty clear that they want to see reports that are unique to different hospital facilities. So even if the language is substantially similar, they want to be able to track that information at the facility level, and I think that that's really an attempt to make it easier for communities to figure out what their particular local hospital is doing, even when it's collaborating with these other institutions. One thing that they did say in the last set of proposed rules was that all or part of the report could be identical, but the collaborating hospital boards, each hospital's board would have to adopt the CHNA report. And this was something that could only happen if collaborating hospitals defined their community, the community that they're serving for the purposes of the assessment, as the same. And then they need to just identify which hospitals are contributing to that assessment report.
So, for example, you couldn't do it if one hospital was only serving a city and another hospital was saying they were serving the whole county.
I think that the key criteria for me is that you can do the collaboration, but how you report it might be different. So there's nothing to say you cannot collaborate. It's really a distinction in how you're reporting that collaboration that changes, and that's where they do get a little bit more technical.
Okay, great. Here's a question about the 990. Is it anticipated that the 990 Schedule H for nonprofit hospitals will require some sort of implementation reporting? For example, in years 2 and 3 of the plan, did the hospital measure progress, or were there successes? Or is the only IRS requirement to assess need and develop a plan every 3 years?
In this last set of proposed rules, the IRS did say that if hospitals describe through their implementation strategy, they have two options. They can either describe how they plan to meet a health need, or they can say, we're not intending to meet this health need, and here's why. If they choose that first option and they're going to lay out through their implementation strategy a description of how they're going to address these needs, as part of that, they do have to say, these are the anticipated impacts that we think our actions will have. Here is our plan to evaluate that impact. And then that entire implementation strategy needs to be filed at this point with Schedule H. And I believe the guidance has also said that, that there needs to be an update every year on those implementation strategies. One of the questions that has come up, however, is that because there will be such a delay with public access to those documents, because the tax year ends, and then as all of us who file taxes know, there's lag time between when you file the report and the end of your tax year. The same thing happens with hospitals. And so one of the things that we have suggested to the IRS is that they would just make the community health needs assessment transparency requirements, which just say you've got to have it on your website and it's got to be available to the public, also apply to those implementation strategies. Because that's, to some extent, really the meat of this process, is not just understanding what the needs are, but really figuring out who's doing what and how that's working. So that, I think, is one area that the IRS has wrestled with a little bit, and we would love to see them bump up the transparency requirements for that strategy.
Great. Here's a question about coordination, and perhaps we can both weigh in on this one. Do you have any thoughts on how coordination of community health needs assessment among competing organizations can be achieved in light of the new federal guidelines? And so, Jessica, specifically, is there anything in the guidelines that addresses coordination among competing organizations? And any thoughts you have on that?
I wouldn't say necessarily in the guidelines, but I have heard some really interesting and thoughtful responses to this from hospital systems that are in areas where there's heavy competition. One of the things that I've heard people say is that when you think about community benefit, these are really resources that, in the best case scenarios, are being targeted to very vulnerable populations who are normally left outside of our healthcare system. And there's very little competition for those individuals when they're uninsured or on, have coverage options that don't maybe reimburse as highly as private coverage. So one of the things that I've heard people say is, wouldn't it be great if we might compete in these other arenas for privately covered patients, but in terms of addressing some of these other needs and meeting the needs of these populations, we shouldn't be in competition. This is an area where we can set that aside and really address these needs together. I think that requires some really thoughtful leadership on the part of the hospitals in question, and it also requires, I think, data that shows that there's a business case to be made around addressing community benefit in that way.
I think that's a great response, and I would add to that, too, is that truly when hospitals look at their mission statement and think about that business case for addressing the population's health, that there are a number of ways that if they're focusing on a broader community issue, their collective action can be even more powerful. An example that I recall from my experience as a local public health officer is when we were working on a statewide smoke-free law, and the voice of our physician leaders and hospital administrators and advocacy around that was very, very powerful. And the movement that was created by competing hospitals speaking together on that issue weighed heavily on many of our local and regional legislators. So I think when it comes to policy issues or infrastructure issues, such as how you build parks and bike trails and work with your local planning departments on doing work that will benefit all of the community, those competing entities can do great work together. Okay. Well, here's a question about costs. Do hospitals and medical centers incur more costs and increased demands of staff in taking on community benefit model strategies? Are there funds to support the process?
So part of the tax-exempt requirement, so to go back and reiterate that component and link this back to tax exemption, the underlying theory behind community benefit, at least to the extent it's tied to tax exemption, is that hospitals are using some of the revenues that they bring in and reinvesting them back in the community, and they're doing that rather than paying taxes. So to some extent, that is where the funds come from. It is something that has to be budgeted for, however, and you raise a really good point, which is that not all hospitals will budget the same amount of money to do this. We know from the data that's been publicly reported that some hospitals spend a lot less than that 7.5% average that I mentioned earlier on community benefit, and others spend a great deal more. It's very idiosyncratic across hospitals, and that has been, I think, part of the push for greater transparency in terms of reporting on community benefit, but it's also been part of the push for encouraging hospitals to have these planning processes in place. The idea being that once we really have a good handle on what the needs and the assets are in the community, hospitals will have another reason to be more thoughtful and proactive about using community benefit to address those issues, which will also require them to think about how they're investing their own internal resources.
Great. Here's a question that may be fairly straightforward. How can a hospital's Schedule H form be accessed?
That is pretty straightforward, but it's not readily apparent. So you can usually go to the hospital itself, and they will either have a link to the Schedule H or you can ask for it. The place that I have found to be a little bit more reliable than that is GuideStar, which is a free website to use, and it has all of the Forms 990 for all tax-exempt organizations. So you can go to guidestar.org and you can punch in the name of the hospital and pull down the Schedule H in that way, or you can go directly to the hospital and request that information. It may be that you can find it right on the website. You might need to do a little bit more digging and try to actually get a human being on the line to find it, though.
Okay. And do Indian Health Service hospitals and or VA hospitals have the same requirement?
The Indian, in this last set of proposed rules, the IRS actually carved out the Indian Health Service hospitals and exempted them from the requirements, which I think is an access issue as well, and it raises questions about how the needs of those populations will be met. In terms of VA hospitals and government hospitals, this is applicable for government hospitals, public hospitals that have 501c3 status. And this is getting into the nitty-gritty of the tax law. There are some government hospitals that do have this separate status. The content requirements do apply to those hospitals, but they have a special exemption as government actors from reporting. And so one of the issues that has come up is how do you know if you're dealing with a public hospital that has that special designation when they don't actually have to report any detail? And so again, this is something that's not been settled. The IRS is actively seeking comment on those hospitals in particular. And what it means practically is that the best way to find out how a local hospital that you think might fit into this category is to ask them directly and find a contact that you can talk to.
Well, great. I know we haven't been able to get to all of the questions in this hour. If any of you continue to have questions that you'd like to forward to us, please feel free to send us those questions through the County Health Rankings and Roadmaps website, and we will do our very best to get responses to you. This has been an excellent hour full of rich information, and I want to thank you, Jessica, for joining us today. Your information has been incredibly helpful. Jessica also did prepare a handout that defines many of these terms and provides a little bit more background on a lot of the content that she has covered today, and that handout is available on the County Health Rankings and Roadmaps website on the webinar page associated with this webinar. You'd also be able to find a copy of the slides there. So we thank you, our audience, again today for attending and for all of your great questions, and wish you well as you continue to build healthy communities. Thank you.
The organizer has ended the session, and this call will be disconnected. Goodbye.